Hi, everyone. My name is Natalie May, and I appreciate you joining in and participating and watching my presentation here for this program evaluation. I am excited to participate in this and share some of my findings through this program. I want to express my gratitude to Professor Bean for all of his help and flexibility and true genuineness in terms of wanting us to succeed as students in this program. And I'd also like to acknowledge the work in my work placement with Concord Counseling, who was able to help me participate and put this program evaluation into practice. So this evaluation was conducted in outpatient community mental health agency where I provided trauma-focused CBT to two female clients in their 20s, while both shared a diagnosis of PTSD. Of course, their trauma histories were quite distinct. One client had experienced a significant loss, while the other survived an abusive relationship with an intimate partner. So despite these differences, they both, of course, presented with common PTSD symptoms and met the criteria for PTSD diagnosis. This, of course, included emotional distress, sleep issues, intrusive thoughts, and fear-based responses. And the desired outcome of treatment in an outpatient community mental health therapy setting was to reduce that distress and help them improve emotional, relational, and daily life functioning. So to help guide this evaluation, I focused on three key questions. The first being, does CBT reduce PTSD-related symptoms overall? Which symptom domains show the most improvement, being distress relationships or role functioning? And are there specific PTSD indicators like sleep problems or hypervigilance particularly responsive to CBT? These questions, again, help shape both the data I collected and the way I analyze client progress. For this project, the implementation of a trauma-focused CBT with these two female clients in their 20s was selected because it's a first-line evidence-based treatment modality specifically recommended for PTSD by organizations like the American Psychological Association and the Department of Veterans Affairs. The intervention was intended to include weekly 50-minute individual sessions focused on helping clients identify and reframe negative thought patterns, build coping skills, and reduce emotional distress, which really embodies the CBT modality. There is a strong body of research that supports the use of CBT for this population. For example, a Cochrane review by Bison and colleagues in 2013 found that CBT significantly reduced PTSD symptoms compared to no treatment or usual care. There was another meta-analysis that I found by Watts in the same year that confirmed these findings, highlighting improvements in both symptom severity and daily functioning. This evidence is particularly relevant to my setting, also where services are typically provided for up to 20 sessions. That's the threshold typically at our agency. And research shows that even brief CBT interventions between 8 to 12 sessions can lead to meaningful change, which aligns well with that outpatient format that I was working in, or am working in, I should say. This is my logic model, which outlines the structure and intended impact of my project. On the left, you can see the inputs, which included agency resources, clinical supervision, CBT materials, and the use of the OQ 45.2, which was the standardized assessment tool used in this evaluation. The activities involved weekly individual sessions, again, that incorporated psychoeducation about trauma, cognitive restructuring, and skill building in areas like emotional regulation and grounding. Under outputs, I tracked both client participation, such as a number of sessions attended, and the completion of pre- and mid-treatment assessments. The short-term outcomes here included a reduction in PTSD-related distress symptoms, improved emotional regulation, and greater awareness of trauma responses. At the midpoint or medium outcomes here, the anticipation was to see expected gains in interpersonal functioning and day-to-day role performance. And then finally, our long-term goals were sustained reduction in PTSD symptoms, better quality of life, and ongoing use of coping strategies. This model really just helped guide my intervention approach and help track progress at both the clinical and client-specific levels. So to monitor client progress and outcomes, I utilized again the outcome questionnaire 45.2, or otherwise known as OQ 45.2. And you'll hear me refer to it as simply the OQ through this presentation. This is a standardized, validated self report tool that measures functioning across three main domains: again, symptom distress, interpersonal relationships, and social role performance. These domains are highly relevant to PTSD, as clients often experience emotional distress, disrupted relationships as a result, and difficulty functioning in daily life. So both clients that I worked with completed the OQ at assessment or intake during that first week, and again at session 10, or their midpoint area. It was looking at this, ideally it would have been the best to gather a third data point at the end, but I'm still working with these clients. So we really here focused on session 1 to session 2. And this aligns again with the midpoint of our agency's expectance of typically, clients will meet for at total 20 sessions during their treatment. So 10 marked the midpoint. The tool, the OQ was administered in session, and there were no issues with data collection as far as I'm aware of. The OQ includes 45 statement items, each rated on a 4-point scale, starting at 0, where clients indicate how often each statement applies to them. So that would be either never, rarely, sometimes, frequently, or almost always. And these responses generate both a total score and then subscale scores for those three domains, with higher scores reflecting greater levels of distress. And again, in my evaluation, I not only looked at the overall and subscale changes, but I also focused on specific OQ items that are most aligned with PTSD symptoms. So I went through the assessment and identified PTSD related statements, and these kind of included disturbing thoughts that I can't get rid of, or I have trouble falling or staying asleep, or my heart pounds too much. By doing this gave me a more targeted look at whether trauma-specific symptoms were actually improving in response to CBT. The OQ again has been shown to have strong reliability and validity in clinical research. A 14-point reduction in total score is what is considered to be a reliable change, meaning it's statistically meaningful and unlikely to be due to chance. So, of course, with this being a self-report tool, it's not without limitations. One client, for example, wasn't sure what the phrase "I feel blue" meant, which highlights how language can affect how people interpret items. And of course, it's self-report, so we have to, again, assume that our clients are answering honestly and most accurately. OQ, again, is still widely accepted and offers a consistent way to track client progress over time, making it a useful tool for evaluating therapeutic outcomes like those in this project. So this was a case level evaluation focused on 2 clients receiving trauma-focused CBT in an outpatient setting. I chose a pre-post design using the OQ, which allowed me to assess those changes from intake to midpoint. While this design is appropriate for exploratory clinical evaluation, it does, again, come with its limitations. There was no control group, which means I can't rule out other factors like life events or natural recovery or additional, services that could have been helpful here and in tandem with the therapy that I was providing. And also the sample size was small. The clients differed in how consistently they attended sessions. Client 1 was highly consistent, while client 2 had a little bit more slower engagement and wasn't meeting as regularly as intended in the beginning. So to address these threats, I used the OQ again and structured all sessions using evidence-based CBT techniques. I also included a symptom-specific analysis of PTSD-related items, again, giving me more of that nuanced understanding of whether trauma-focused strategies were helping address the right symptoms. And both clients were collected data at the same point in terms of their 10th session, if you will. So to monitor again the progress and outcomes using the OQ, each client completed the OQ at intake or assessment at week 1, and then again during session 10 or week 10. Which is the midpoint of their expected 20-session treatment plan. While I only had 2 data points due to the project timing, I visualized the scores over a 20-week timeline here to reflect their trajectory and treatment potential. The lines between weeks are flat to show that data was not collected during those gap points. In this graph, obviously, you can see client 1 is in blue and client 2 is in green. Client 1 started with a total OQ score of 120, which is well above the outpatient norm of 86, shown by the orange dashed line here, and the non-clinical cutoff of 63, which is commonly cited in literature as the threshold between clinical and functional range. By midpoint, her score dropped to 88, which is a 32-point decrease, which exceeds the 14-point reliable change index defined by Lampert and colleagues, and that indicates statistically a significant change, which was really awesome to see. Client 2 began at 91 and reduced to 78, while that 13-point drop is just under the statistical threshold. It still represents meaningful improvement, particularly since her score dropped below the outpatient normal line. So the pattern we see here shows non-overlapping improvement, which aligns with the visual analysis methods like PEM and PND often used in our small N designs. Both clients show a clear drop in distress from baseline with no overlap between intake and midpoint values, suggesting a positive treatment effect, which is awesome. While neither client crossed the non-clinical threshold of 63, the downward trend, especially for client 1, is really promising. And with continued sessions, we might expect them to reach the non-clinical range by week 20. So in short, the data shows progress is being made, and the therapy appears to be helping reduce PTSD-related distress, which is awesome. To answer whether CBT reduces PTSD-related symptoms, again, I examined individual OQ items. I won't go into too much depth here in terms of that, just due to the limited amount of time, but I thought it was worth reporting this since it was a big evaluation question that I did want to address in the second and third evaluation questions. And so these item level trends suggest that emotional arousal symptoms and negative thinking patterns were particularly responsive to trauma-focused CBT. Especially when the clients were consistently engaged in treatment. So client 1 showed notable improvement across most PTSD symptoms. Client 2 had a little bit more mixed results, likely influenced by lower session engagement, but also just outside contextual situations that were likely impacting their ability to participate in treatment. So overall, the data suggests that trauma-focused CBT had a positive impact on both clients, which is wonderful. Client 1 showed a statistically and clinically significant reduction in total distress with improvements in both overall functioning and specific PTSD symptoms like sleep issues and intrusive thoughts. Client 2 also improved, and though more modestly, this aligned with her, might have aligned a little bit more with her lower engagement and slower session attendance, but still very positive to see nonetheless. While neither client, again, reached the non-clinical range by session 10, the downward trend in the OQ scores supports that CBT is a promising approach for treating PTSD in young adult women. If I had to, answering the question of how do you use the evaluation information to guide practice or program decisions, this really helped me tailor interventions for each client and validate the use of structured CBT techniques in trauma care. On a broader level, this process demonstrated how ongoing outcome monitoring, using even just a few data points, can guide clinical decision-making in a meaningful way. I also found that reviewing the scores with clients was really, really helpful in better understanding their presenting problems, creating treatment goals, and just assessing overall how they interpreted change and progress when we completed the OQ at the midpoint. It was really valuable to use the OQ and to hear from them in terms of the progress that they were seeing or the areas that they would like to work on. If I were to do this again and do it differently, I would definitely, I think I'd be more interested to aim at collecting more frequent data points, maybe every 3 to 5 sessions, to better observe symptom trends over time. I would also consider adding a brief qualitative component, like client reflections or even just my notes in terms of to be able to give more context to these numbers. It was again, it's very positive to see these numbers and what they are, but also having understanding of the qualitative responses and reflections by my clients is very meaningful as well in terms of how they incorporate CBT into their lives and see the benefits of it. And lastly, I think I would like to explore how specific CBT components like cognitive restructuring versus relaxation techniques are tied to change in specific symptoms here. I think that this could help me further refine my trauma-informed practice and see the impacts of CBT. Here are some of the resources that I utilize, of course, through this presentation. But I want to thank you all for bearing with me and going through this 15, 16, close to 16-minute presentation. And I want to wish you all the very best in the home stretch of our program here. Thank you.